So, very good afternoon. We are already running late, so I'll finish it as fast as possible so we can all have lunch. So, this talk is basically again the lesioning part, and then most of the talks have been taken care of, including all the neurosurgical procedures. This is one of the procedures which we do at our institution. This is dorsal root entry zone lesioning for brachial neuralgia. So this will be the progression. Like I'll introduce first what is DREZ, and then the anatomy, and then the indications and our own experience with the video. So as you can see here, that dorsal root entry zone is the area where it lies posterior lateral to the. It's a posterolateral sulcus. Basically, it lies lateral to your entry of the roots on bilaterally. So it has bilateral posterolateral sulcus. It includes these rootlets, dorsal rootlets, and something known as the tract of Lisor, where this is a white fiber bundle where all these fibers enter into the dorsal horn. So that forms a tract of Lisor. And your dorsal horn laminae, that is Rex laminae, we have studied in our MBBS days that we have 10 laminae inside the thing. So the pain producing laminae are the dorsal Rex lamina 2 and 5. So these are pain producing lamina. So including all these components, this is the part where we perform the lesion for the pain. So this is, so if you see this figure, yeah, oh, it won't stop. So you see here that when the dorsal root, if you take a cut section of the dorsal root, the far away from the entry point into the spinal cord, these are arranged randomly. Yeah. So we have from the physiology days that we know the fibers, the signal carrying fibers are divided into A, alpha, beta, delta, and C fibers. So A, delta, and C fibers are basically the pain producing fibers. They are small fibers, and the large fibers are the they carry the proprioception and other senses. So as you come closer to the point of entry into the spinal cord, that's a dorsal horn, these start rearranging themselves, and then you can see the larger fibers go more medial, and these are towards the lateral. And as you come here, these fibers get into more, the tract of Lisor is arranged in such a way that these fibers are, they rearrange themselves. So that is the reason that our, the tract of Lisor, that is a part of the tract of Lisor, and then the part which is just lateral to the root entry is the one we cut it and spare the large fiber part. So mechanisms have been described variously. So the Rex lamina, which is the lamina 2 and then the lamina 5, they have Denny Brown described that these in the animal studies that there is a state of tonic discharge. These cells are involved in the pain production. So now the latest concepts in the morning, Dr. Renu Bhatia described about the wide dynamic range neurons which are present in these region, which are responsible for this neuropathic pain. And there are various peripheral as well as central mechanisms like spinal and supraspinal mechanisms which are actually due to post deafferentation, these changes happen and then the pain starts coming up. Now, it's basically a deafferentation pain following brachial plexus avulsion injuries. So most of our patients who come to the trauma center here, they do have this avulsion injuries due to stretch probably or high vehicle motor accidents. And it is well visible on the MRI that these patients have the pseudomeningoceles. So this is basically a preganglionic injury, which is a prerequisite. And then these patients do have this deafferentation pain. Approximately post-injury, 70% of them have pain, which are managed with medications, of which around 30% develop this refractory pain. And they don't have a cure, and it's kind of suicidal pain. These patients have the tendency I think Dr. Deepak's first patient was almost, he had committed suicide, and then somebody saved him. Then we had to, when we performed the surgery, now I think he was in the police department, so he's now happy. So predictors of outcome like intermittent, the sharp stabbing ones, segmental pain, preganglic root avulsions, and complete BPI. These are the patients who have better, they respond better to the pain following DREZotomy versus the other types. And in the literature, they say lumbar has better than cervical and then thoracic. So there are mainly for the intractable brachial plexus avulsion injuries. This is one of the best indications, like the other indications being the sacral plexus avulsion and then craniofacial pain. Dr. Girish in the morning had talked about the nucleus caudalis lesioning, where it's similar to the DREZotomy, and post-herpetic neuralgia. Even DREZotomy is done for spasticity, so where it takes care of phantom limb pain. So various indications. Sorry. So there have been various techniques described. The first one was by Marc Sindau. He from France, and it was his med school thesis, and it was the first. He was the first to actually describe the mechanism, as well as describe the technique of performing this microsurgical DREZotomy. And then came the technique by Nashhold, which was RF lesioning, which was again published, and then various other modalities came in, like laser and then ultrasonic. And lately we published this technique of not using any lesioning equipments. Rather, we try to use a mechanical disruption, where we just use a micro scissor and then we just cut into the dorsal horn region. So basically, this is because the other modalities use some form of energy, like the Sindau's technique used the bipolar coagulation, where the heat used to, probably it led to more complications, because the microvasculature actually dips inside the sulcus, and then the heat actually causes the microvasculature to get damaged. And similarly, the RF, again, it's a lesioning, laser and ultrasonic. So in our technique, we generally use just the micro scissors, very fine micro scissors, and then do a mechanical disruption. So this was a classical technique of Sindau, where it was the posterolateral sulcus is sulcomyelotomy is done, opened up, and then you do the lesioning using a fine tipped micro bipolar at 1 mm intervals. And the entry angle will be somewhere around 40-45 degrees, so that you actually go in between the fascicles, like the dorsal fasciculus, you have the gracile and cuneatus, and then laterally you have the spinothalamic tract. So you have to enter in between them. If there is a change in your or orientation, then you might end up damaging one of the structures, either the dorsal columns or the spinothalamic tract, leading to complications. So again, the Nashhold's technique is basically, the technique is the same, but then they use RF probes at 1 mm intervals, and then they burn. So the depth of the lesioning should be around 3 mm. That is what takes you to the Rex lamina 2 region, where the pain producing neurons are present. Various modifications have been done. This was from Japan. They had only 10 cases, where they have gone more deeper, like to the lamina 5, and then they have done the lesioning, and they found excellent result in 100% of patients, but again, it's just 10 patients. So coming to our technique, this is, we have described, and it's already published. The video is also available on Neurology India website. You can go through. So it's a unilateral laminotomy, and then we use the micro scissors and then do the disruption. So I'll be showing you the video briefly. So this is the figure which I have made for explanation. So you can see here the scissors go in the dorsal horn at around 45 degrees, and then the lesioning takes, the lesioning started just lateral to the entry of the rootlets into the dorsal horn. So this posterolateral part, you lift up the root and then you go along it. But in avulsion injuries, obviously the roots are avulsed, and then there is a region where there are no roots. So you'll have to identify the normal root above and below, and then you go draw a straight line and then go in through that sulcus so as to get the procedure done. So generally we mark the tip of the scissors at around 2 mm so that we enter our area, like Dr. Girish was showing about the bone wax. He puts a bone wax and then the rest of the tip cuts it. So we usually mark with a kind of permanent marker and then do it. So these are the intraoperative figures. I'll come to the video, which is at last. So this is our experience. We had around 56 patients, of which 9 patients had lost to follow-up. Majority of them were road traffic accidents, and the root avulsions was found in C5 to D1 on MRI in majority of the cases, and then we had the follow-up is around 5 years follow-up approximately. So we had, following this procedure, excellent results in approximately 80% of patients. The excellent outcomes were 75%. And if you combine we did the numeric rating scale, where more than 75% was included as excellent, and good outcome was between somewhere 50 to 75%. So more than 50% reduction was seen in 80% of our patients following this surgery, as you can see here. And 4 of them had recurrence of pain in the long run, and then 2 of them were reoperated, although reoperations are very difficult. So, but still, we could have 50% good outcome in the operated patient. 2 patients did not have significant relief. They still continue to have the pain. Complication-wise, you can have motor weakness because you have corticospinal tract in the vicinity, and then you can also have dysesthesias, paresthesias because of this involvement of the dorsal columns and the sensory part. Urinary incontinence can happen. We haven't seen any. CSF leak, of course, is one of the complications. So if you see this table here, most of the complications which used to happen in the past, basically you can see that motor is 50% and sensory is 75% in the initial Nashville series. Sorry, and similarly the complication rates were higher. But then in our technique, since we are not using any energy based lesioning, we are just using the mechanical disruption. So that is probably one of the reasons that we have had some good outcomes. And this I discussed in the meeting with even Professor Sindhu. I had met him at WFNS. So he was actually, we talked about this, and then he shifted himself to doing a mechanical disruption since lately. So he was very happy about that, and then he was actually wanting to see the paper. So this is the various techniques which have been used with radio frequency, laser, and so ours is the 3rd largest series published in the literature, I can say, and then we have equally good results without using any fancy equipments here, which is cost effective also, and then it can be used with a basic neurosurgical setting, even in a peripheral hospital. Obviously, the expectations are like pain relief, quality of life improves in these patients. They have a better sleep quality because it's a suicidal pain and they don't sleep and they have this pain, horrible pain. So, and they call it a suicidal pain also. And complications I already talked about. So these are other procedures which are alternatives, like selective rhizotomies are there, and then dorsal column stimulation, spinal cord stimulation has already been talked about. The cordotomy, I'm not sure. Dr. Ido might be able to tell about it. Cingulotomy, yes. And this is the video. I'll end with this. So it's a 55-year-old gentleman. He had a right upper limb brachial plexus avulsion. He had complete grade 0/5 on the right upper limb, complete loss of sensation. It was a pan brachial plexus injury, but he presented with severe onset pain. On MRI, you can see there is pseudomeningoceles. That is evidence that there's a root avulsion. So we do it in prone. We do a hemilaminectomy because it's on the right side. So we do a right-sided. We did a right-sided hemilaminectomy in this case. You can see here. We open it in the midline, but then we strip off the muscle on one side so that it's good for doing a hemilaminectomy. So this is the hemilaminectomy which is completed. Now you open the dura in the paramedian area. So now you can see there is no root seen here. There is normal root up and one below. So this zone has no roots because it's completely like avulse roots, and then they have undergone degeneration. That is the area where we have to go. And you start by going from one root, couple of roots above, normal roots, because when the pain fibers go across the opposite side in the spinothalamic tract, they go up 2 levels and then go. So that is the reason you go 1 to 2 levels above the normal level. You can see the descending vessels there. Here, these are the microvasculature which are dipping inside the sulcus, and then this sulcus is between 2 fascicles. It is easy and then it opens up, and you in this case, because it is a post-traumatic avulsion, there were gliosis and then which happens to be seen. So, and you can see we have marked the tip of the scissors with a marker so that we don't lose our depth of lesioning. And then we go up to 2 to 3 millimeters depth. This is how it opens up, and then that is the end of the procedure. So you can see the marking there. So that is how it opens up. So we go that level of depth, and then it's an avascular plane basically. Once you know it, and then you are there. So take-home points: rhizotomy is a very elegant procedure, very excellent for post-brachial plexus avulsion injuries, and then the pain relief is instant. The moment the patient comes off the OR, he is like unbelievable. There is no pain which he was suffering, and then even it can be used for spasticity and other indications. Continuous sulcomyelotomy that is done, and then just mechanical disruption has better probably outcomes in terms of the complication profile. So, and it's best suited for peripheral setup where limited resources are available. So these are a few of the publications which we had, and thank you very much for patient listening. And
any questions? Yes.
Excellent job. When you do microsurgical rhizotomy, I hardly use bipolar to make the lesion actually. Bipolar is just making the PL this one, and I put the roton to make the lesion. So it's as good as your technology.
Yes.
The roton.
Yes.
We don't use the continuous bipolar energy as Sanju described.
Yes.
And that's one thing. Second thing is, if the patient has completely flail and anesthetic arm, I would definitely go for DREZ. But if they have quite significant preserved sensation, we always try spinal cord stimulator first, and if it fails, we do DREZ.
Yes, that's what I showed, that these are the alternative options, like you can use it. But then for those patients with quite severe pain, and then the cost factors, that's the reason probably we didn't get a patient of spinal cord stimulation here. And it's very good for resource setting, which are limited by resources. So I think that is even many of them are not aware of that such procedure is available. So
we may use cordotomy for failed rhizotomies.
I've not used cordotomies for chronic pain.
So Dr. Milind was saying about focal deafferentation pain, probably motor cortex stimulation you would like to. So are these the cases where motor cortex stimulation can work?
Yeah. But then this is much more simpler.
Yeah.
No implant, no programming, less expensive, and gives very good results.
Yeah, it's a one-time procedure, by the way. That is another advantage of this technique.
Also, I would just like to add that for those who fail this, you can always repeat it. And again, excellent results after sitting. We have even given it 3 times for the patient.
I had a patient, we have done twice, still he's having pain. So I was just
that can happen in a because Dr. Deepak and we have done like analysis. So 4 patients had a recurrence, of which 2 we read it, and then 2 had actually good outcomes. The remaining 2 did not have that
Selection
much.
is most important. There are certain patients who deep follicular pain are better treated rather than those patients who have other kinds of pain. So again, there are so many variabilities in this.
So that is why I was just exploring if cordotomy may be used or not.
So thank you very much.